Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Welcome to a special edition of VITALS. Today, we're at the headquarters of the Cleveland Browns at their cross-country mortgage campus in Berea, Ohio. I'm Dr. John Langell, the president of Northeast Ohio Medical University, and I'm pleased to bring you VITALS in collaboration with University Hospitals of Cleveland. University Hospitals is also the official healthcare partner of the Cleveland Browns. VITALS is an open forum to hear from national leaders who are transforming healthcare using the VITALS tools: value, innovation, technology, advocacy, leadership, and service. Today, we'll hear from Dr. James Voos. Dr. Voos is the chairman of University Hospital's Department of Orthopedic Surgery and the Jack and Mary Herrick Distinguished Chair of Orthopedics and Sports Medicine. Dr. Voos is also the head team physician for the Cleveland Browns and is the immediate past president of the NFL Physician Society. Please join me in welcoming Dr. Voos as he shares his insights on leadership.
Thank you for the opportunity to speak with the group again. This is our second year of doing this together. We had a lot of fun last year, and we met quite a few of the medical students who have actually still coming up working with our research team. So there's been a lot of nice connections. And I've been down to NEOMED quite a bit. We utilize your laboratory facilities, which have been excellent. So we've spent a lot of time at NEOMED. So it's nice to have a lot of these cross connections that all occur with events like this. So there's multiple opportunities for us all to connect again here after this. I wanted to introduce myself, a little bit of my history of how we got here for 2 seconds, and then our current roles. And then we'll talk a little bit about the broader scope of how healthcare impacts professional sports. And from the pathway part of things, I want to bring it up in that you never know where your life is going to take you. So I'll take you on just a 1-minute journey, and then we'll get on to the more exciting part of the talks. But I grew up in western Kansas, so I grew up on a farm, a town of about 3,000 people. My mother was a nurse, dad worked in the lab. So started working in a hospital when I was 15 years old, and I could probably check the box of working in every single part of healthcare, from food service to sterile processing to moving patients around to all the way through. So I feel like I'm a factory floor doctor that started from the beginning part of things moving forward. And we went to medical school at the University of Kansas, but was fortunate to be selected at the Hospital for Special Surgery in New York, my orthopedic residency. And that's where I was really exposed to the sports medicine world. I played college football, so I had a little bit of exposure from that end, but it was really entering a program that provided the education and the exposure to this, which was really the on-the-job training. So it was a wonderful opportunity to go from as small of a town as it gets to as big of a city as there is, and stay there for both residency and fellowship. I went back to Kansas City, where we're from, and started practice the first 4 years in a private practice that took care of the Kansas City Chiefs. And that's where I thought I was going to spend my whole life. We were back home near everyone, and in a totally private practice model. We owned the dirt, we owned the building, we had the whole practice ourselves. So that was one way of practicing, and thought that was what we were going to do forever. And we're here today because Mr. Haslam found me in 2014 at the NFL Combine and said, hey, we're doing this thing in Cleveland. We want a young, energetic person to help us go along for the ride with this. And I'll see you in Cleveland on Tuesday. And he patted me on the shoulder and walked away. And somehow the Jedi mind trick worked, and I was on an airplane on Tuesday to come up here in 2014 and work with university hospitals and with the Browns to start both our community sports medicine program as well as reinvent the healthcare part of things here with the Browns. So it's been 12 years in this role. And I tell you that, and that I would have never thought I lived in New York City in my life. I would never thought I would live in Cleveland, Ohio in my life. I didn't know I would go from the most private of practices to the most academic of practices. So it's one of those things that we always use the term, I'm just going to keep my head down and work. And I would challenge that and tell you to focus on your work and be really good at your work. But I would do the opposite and keep your head up, because you have no idea what the opportunities are going to be around you. Your life takes you on amazing adventures. And if you keep your head up and you're looking for those opportunities and you meet people and you keep those relationships going, it's a really fun adventure to see where things are gonna go. So again, these are all my life adventure. If you asked me to write it down 1,000 times, it wouldn't even have come close to how it's all worked out. So it's prepare yourself, take advantage of this great opportunity. That way you've learned everything you need to learn. You've met people, you've shadowed in the environments. That way, no matter where life takes you, you're ready to go for it. So for what that's worth here, that's where we're sitting here today. And so we wanted to blend the fun part of this in a healthcare talk is being able to blend all of the things we do inside of the hospital with what we're doing, the care we're delivering outside of the hospital. So my day job is I'm an orthopedic sports medicine surgeon. So my favorite thing to do is still to be in the operating room and do ACL surgeries and elbow surgeries and all of that. So that's still our day to day. We say our practice, or my practice, is from Pee-wee to pro, and any given day I could operate on a 12-year-old or for a professional athlete. Again, it's one of those things where you've had the exposure of dealing with athletes of all ages. So that's the day job of being a sports medicine doc. The last 7 years, I've been chair of our orthopedic department. So Dr. Langell is very inspirational in being a person that knows how to wear many hats, so leadership and practicing. And so it's one in healthcare here currently. It's a different perspective when you're not just looking at your own success. A big part of your goal is seeing other people succeed and helping all of those in your division deliver quality health care. So it's a really fun part. If you take the leadership route, it's really setting yourself aside and really how can you pave the way and remove boundaries for your partners to be very successful. So that's the other side of the job. But the two fun parts to talk about today are one in the sports medicine side of things. So we've been Browns doc now for 12 years. I was the assistant doc for the Chiefs for 4 years, and then did my fellowship with the New York Giants. So it's been almost 17 years. The last 2 years, I served as the president of the NFL Physicians Society. We had a really unique opportunity to not only represent the Cleveland Browns in Cleveland, but to represent all 32 teams in the global side of what we deliver for healthcare and how we standardize things across the board. We were very fortunate to have the Haslams provide us with a really unique fund, which 2 years ago we created the Haslam Sports Innovation Center, which is a $20 million, for lack of a better term, a nonprofit investment fund, where our sole goal is to enhance the lives of athletes. So we identify companies that are committed to safety in sports. We invest in them. We use what we call the Living Lab, that's all of us, to test all of those equipment and programs. And then we go tell the story, and it's kind of fun to do the marketing part of things to tell the story. So we're going to blend a little bit of that here together this evening. And we got a couple of the things to talk about, and probably the most important, but maybe the most boring first. But in healthcare, it's a very important word, and we use the term standardization. And in some ways, it's a bad word because you think, well, this isn't cookie cutter in factory medicine. In another way, it's one of the most important things we can do for safety. So when you think about somebody, when you're running a code, or somebody that comes in with a stroke, or you're doing a cardiac cath, or what you're doing in the operating room, having that standardization, something that you can repeat over and over again where it almost becomes muscle memory, is incredibly important. And so that's one of the balances we're trying to do in the hospital, that all of the day-to-day things, those core parts of how we deliver care, again, become muscle memory. That way you can deal with the things that sit outside, the really challenging case, or I've got to spend more time, this is more of a crisis mode, so that all your day-to-day operations happen together. Forever in professional sports, there was no standardization, and we would really just focus on reacting to whatever happened after someone was hurt. So forever and ever and ever in sports, until maybe the last 5 years, that it's really become a thing. All of us as healthcare providers, from our athletic trainers, physical therapists, the docs, you were there. You obviously all the athletes train and work out, but you really weren't working until after the athlete's hurt. And so then you jump into action, and everybody's figuring out what to do to get them back out on the field. Now, with our utilization of this term standardization, and athletes are making more money, right? We want them to play longer. Our college athletes are making an awful lot of money. And our high school athletes in the state of Ohio, the NIL part of things, that is all legal in the state of Ohio. So our that demand, for better or for worse, so it's what our customers and our patients are in that environment. And so as healthcare providers, we're exposed to that part of how do we want to take care of them, to take the optimal care of them. And then you could argue there's a liability component of how can you make sure we standardize that to make sure we're protecting ourselves as well. So from the NFL standpoint, that was one of our big things to solve here over this last 2 years, is standardizing what we do before the game even starts. Everybody's sort of emergency action plans. Every facility, or before every game, has an emergency action plan. It used to be every stadium kind of did their own thing. You had your ambulance people, you had your heart person, and you did your best to kind of put it all together. And we saw with the Damar Hamlin part of things in Cincinnati and Buffalo, how important that is to have an emergency action plan ahead of time. So now at every single stadium, whether it's a practice, whether it's a game, whether we're playing in London or Brazil, that emergency action plan is exactly the same at every single place. So we all work weeks ahead of time to talk about who's in charge of each part. 3 times a year, we practice it here live. So we have all of the physicians, we have the athletic trainers, we have our EMS folks on here. We got some of the students that worked with our physicians ambulance. All of us get together and rehearse and practice all of those scenarios. What happens if someone has a heart attack on the field, or they dislocate their knee, or the coach has a stroke on the bus, right? And so what do you do in each of those scenarios? Something happens in the airplane, and that knowing who is going to be there, what physicians are there, what athletic trainers are there. And if you don't want to be a sports medicine surgeon, on the field any given day, we have an anesthesiologist who's an airway doc. In fact, there was a couple players in the last couple of years have had to be intubated on the field. There are 4 neurologic consultants at every single game. And then we have our emergency response physician, which is typically an ER doc. So I would argue, if you were going to have a healthcare emergency, the best place to be is on an NFL field on a Sunday with as many healthcare providers as are there. So that group rehearses over and over again, what do you do in each of these scenarios? And the remarkable part is that in healthcare, we don't think that's totally unique, but we've really taken what happens in the trauma bay when someone comes into the ER and moved it onto the field. So it's a trauma bay that's practicing in front of millions of people. And so there's a whole art form as to how you do that in front of millions of people, and everyone look cool, calm, collected, take the best care of the athlete, and safely get them off the field. So that standardization is really important, and I bring it up in that what you're practicing now, if you're interested in sports, translates onto the field, and you don't have to be a sports medicine doc. In fact, the one thing that we appreciate the most is our cardiologists, our neurosurgeons, our ER docs that are all there with us to really help us, because these athletes still have medical issues. So it's incredibly important that we have a comprehensive healthcare team. So 60 minutes before every game, we have what's called the 60-minute medical meeting, where everybody gets together. We review who's in charge and what all those quick emergency action plans are. So really unique things, again, maybe not as exciting to talk about, but probably the things that save the most people's lives and really shows how important having a comprehensive healthcare team is. But the fun part of standardization is a lot of what we do with our rehabilitation. We have so many toys available to us now. So for example, if someone strains their hamstring, we go back to the past of, okay, we waited a week or two, okay, they look pretty good running, they say they feel okay, all right, I ran some routes, everything looks pretty good, let's go back out there and play, right? Very arbitrary, not a whole lot of necessarily science to it. Everybody gets kind of a gestalt, everybody kind of had their own little way of doing it, and that's great, but there's about a 20% risk of recurrent injury. So the number one reason an athlete is not on the field in the NFL is a soft tissue injury. That's the number one reason for missed time. So a hamstring strain, a calf strain, a groin strain, which makes a big difference. In a week in the NFL makes a huge difference whether if you're back in 5 days versus 8 days, that's a game. That makes a difference. So we've really looked at standardizing the process. The fun part, if you're a data person, now every time the athlete steps on the field, whether they're working out, practicing, or playing in a game, they're wearing our GPS devices, our wearable tech devices. So every time someone works out, we know how long they worked out, what their top speed was, what their average speed was, how many times they spun to the left, how many times they spun to the right, how fast you accelerate, how fast you decelerate, what's your stride length between your right and your left leg. And you get tons and tons and tons of data, huge big data, almost data overload. We have ultrasound here on site, so now we also track our muscle healing with ultrasound. How much fluid is still sitting in the muscle fibers? Are the muscle fibers still attached? Are they contracting like they're supposed to? So now when somebody strains their hamstring, we do an MRI. You can grade the level of hamstring injury it is. We know from them training what their normal value is, how fast do you typically run, how quick do you accelerate and decelerate normally. Now when you do the rehabilitation, we can watch you run and change direction. And now I can go with our head athletic trainer to our general manager and our coach and say, okay, it's been 2.5 weeks that this athlete has matched their average speed. They've hit 90% of their top speed. They're decelerating like they typically do. There's no fluid in their muscle and their muscle is contracting. There's even another layer where we do these muscle oxygen sensors to see how much your muscle consumes oxygen. Now there's some data, and as we've done that in the NFL, that number from 20% has started to creep down a little more. And so the best ability in the NFL is that the joke is the best ability is availability, right? So now we can really dial in that level of care to help the athletes get back. So that's another part of the standardization of being able to look at these data points. And that helps us when we talk to our college and our high school trainers that may not have all of that data, but at least you can pick and choose and start to dial down parts of this. Hey, these exercises work well. These functional movement part of things work well. If you're going to use maybe not as expensive of a wearable tech device, here's the things to look for. So it's helped us to affect our other athletes from that standpoint. And then the final part with this standardization has come with the surface and what you're wearing. And there's always a debate, we were just talking about this before, between grass and turf and which one's better. And when you look at it, they're actually pretty similar when it comes to the level of injuries. It all depends on who's getting interviewed and talking about, but the challenge is how well that turf is kept up. You've seen grass in Super Bowls that's brand new grass that spins away and it's mud and it's terrible and it doesn't work, or very poorly kept turf is a similar part of things. So really it's the standardization of the surfaces. Soccer and FIFA and Europe have been doing this forever. So now all the fields get tested. They have to have that same level of give in terms of there's actually a little machine called the Beast that goes and checks all the surfaces. Similarly, our high school and colleges, while they may not be able to do all of that, all of the data we've learned, what turf is the most ideal, how often do you need to rake it and do the maintenance part of things, what's the best way to maintain your grass. So all of those things have been able to trickle down to our other athletes. And then finally is in the equipment, every helmet and every cleat that the athletes wear on the field has been tested in the lab. And you'll hear now that the helmets have to pass the NFL collision test. If it does not pass the test, you cannot wear it on the field. For a while, it was just recommended, but now in order to wear a helmet on a football field, it has to pass that standardization test. And this last couple of years is the first time that helmets have ever been created to reduce the risk of concussion or reduce the risk of head injury. Up until about 2019, the sole goal of a helmet was to prevent a skull fracture. That was the only thing that a helmet was designed for, and to keep you from getting your eyes poked out and things like that. It wasn't until 2019 that helmets were started to be designed to reduce the risk of head injury. So it's been a really unique thing to see. There's several new helmet companies, whether it's Physis or Zenith or Light, that have all been formed that are if you look inside the helmets now, they look like NASCAR crumple zones, right? All these little customized zones inside of them. And the nice part about that of the NFL standardization helmet program, now all of your bike helmets, the kids' bike helmets, military helmets, are all utilizing this technology to reduce the risk of head injury. So again, it's nice to have the standardization part of things, while maybe not as sexy, is probably our most important from a safety side of things. Flipping the other way, the innovation side of sports medicine has grown more than ever. And that's what we get really excited about, those of us who are in that part of the movement of medicine. And again, the demands of our athletes, really investing in the length of careers, the careers of our athletes, parents demanding that their kids playing youth sports have all of the resources that they need. It's become this market, or this industry, again, is another way that's really driven innovation for us to serve our patients. And a couple examples where we've been able to partner with the NFL to do that. The first is in regenerative medicine. Right? There's all these stem cells and all the things that the athletes want to do. There are very strict criteria that the NFL has in terms of what you can put in your body and not, to keep you safe. It's just like at the Olympics, very similar things, so that there's a level playing field. But we often had many players traveling all over the world to go get stem cells, in Panama and the Cayman Islands and wherever. And with the best of intention, a lot of them would come back and have an infection, or they would test positive for a banned substance because you weren't sure what was going on in that lab. So one of the things that we sought to do at our program is be the voice of reason for regenerative medicine, and to provide what our athletes are looking for, but do it in a very scientific fashion. So we started this a couple of years ago. It took us 2 years and about $250,000 to get through all the FDA regulatory plan. I went to our cancer lab. Again, this is where we all work together in healthcare. Dean Gerson is our dean of the School of Medicine. He runs the National Center for Regenerative Medicine, the Case Comprehensive Cancer Center. He's been growing stem cells for 25 years with FDA approval in a GMP lab for people with blood-borne cancers, right? He's got the expertise, and they do it in their sleep. They're really good at it. So we sat and talked, and Arnold Kaplan, who sadly just passed away at Case Western, was the person that discovered mesenchymal stem cells. So the term MSC that we all think about, the stem cell part of these, was actually discovered right here in Cleveland, which is a really nice little thing to have, a little nugget of Jeopardy trivia. So I met with Dr. Kaplan, I met with Dr. Gerson. I was like, I know there's no reason our worlds should collide, but this is why we should do it. And we developed a stem cell protocol where we harvest your cells, and we take those 10 cells and the growth factors and grow them into 50 million cells. And so not only do we know exactly how many cells are in it, we also do the assay of all the cytokines and exosomes that the cells produce. So the goal was, if you're going to come and have this injection, we're not going to give you an over-the-counter ibuprofen. We're going to give you like the prescription anti-inflammatory version of stem cells, but it's got to have a label on it. So you know exactly what goes in your body. So the FDA does not allow you to more than minimally manipulate stem cells. It's against federal law to mess with cells unless you get approval to do so. So we had the approval to grow the cells. But now not only do we have this higher concentration, I equate it to, like, you get a water. If you drink a water right now, it has a label on it, right? Everything you do has to have a label. But people are entrusting folks to go get these injections of whatever with peptides and this or that, and you're just trusting people to put, and sometimes other people's cells in your body. You have no idea whose cells they are, how are they standardized, how are they cleaned, what's in there. There's no label, but yet people are paying tons and tons of money to do it. It's kind of crazy when you think about it. So our goal was, if we're going to do this, we're going to put a label on it, just like you flip over your water bottle, that tells you there's nothing in it and there's 0 calories. We're going to make sure that it tells you there's this many cells, there's this much VEGF, there's this much of your insulin-like growth factor or whatever, so you know exactly what's going in your body. So we did the first 16 patients. Here, the phase 1 clinical trial, 5 of them were professional athletes, several on this team, some of them that you would very much know their names. And we had a wonderful first response to it. It's just a safety study for the first 16, so we know it's safe, but fortunately a lot of them had a great outcome where their MRIs actually showed some structural improvement, which we did not expect to see. So we're getting ready to start phase 2. So that type of innovation is one. So it's, again, you're a basic scientist or such, and part of the reason I'm bringing this up is we dig deep into medicine to help out our athletes. So no matter what specialty you do, you have the opportunity to impact our athletes. We continue to develop wearable tech devices. So those movement wearable tech devices you talk about now we're integrating them where they have temperature sensors, lactate sensors, an EKG on them, and then an activity monitor. So you can imagine going out to Lodi to a soccer tournament where there's 1,000 kids. We can now, with drones, float drones up and create our own internal network, which is possible to do now, have every child wear one of these wearable tech device, and you can pick up if somebody's going to overheat, if they have a cardiac arrhythmia, has somebody been out on the field too long. Imagine now you can do these large scale, or a marathon, you float the drones along the marathon route or a triathlon, whatever it may be. You imagine if you picked up somebody as they were developing a cardiac arrhythmia or getting ready to overheat. Again, you have the opportunity to save lives. And those type of innovations, because we've used the wearable tech devices here, are the type of things we have the ability to impact our athletes with. So it's been a really unique part of things. The fun part with innovation I'll also bring up where it really gets personal is, where I trained, they always wanted you to look the part. We all want to wear sport coats on the sidelines. We don't want to dress like fans. So my team, we always wear sport coats. The guy I trained with really pushed us to do that. So I kept getting, all my jackets would get bleed, the bleed on them, they sweaty, and then you'd go down to examine something, you'd rip the back open. Oh my gosh, this is terrible. This is really expensive. They keep up on all these coats. So I kept trying to sort out what are we going to do. And I met with the guys that used to work for Under Armour that developed a scrub company that rates very high-end scrubs with fluid-resistant fronts, and they breathe in the back, and really it's like the Bury of scrubs. And we partnered with them with our innovation group, said, you guys, I know this is crazy. I have an idea for a sport coat that it's flexible, it can breathe, it can stretch, I could sweat on, it can, can I travel in this where it looks, I want to wear athletic clothing, but have it look like it's formal. So I've got it on here now. Yeah. So they're all, so we made 20 of them. And so it's sport coats where the armpits breathe, you can sweat in them, so it's a really fun part of it. It's not a self commercial as much as it's in keeping your head up, you have a way to impact your environment. And as you start to live in this ecosystem, you realize you have a lot of control over your life and you have a chance to interact with a lot of people. So it's one of those ways where you can really push innovation forward and try to help folks around. And this is one where it's nice to have all the docs wearing these fancy coats here with us here. The final two things we'll end with, and I know I've alluded to it, sports medicine now, and we just did a big video interview at the NFL Combine last year with Dr. Alan Sills. He's the chief medical officer for the NFL. We had a group of physicians on to talk about caring for athletes. And when you look in the NFL, team physicians, we now have a lot of ER docs that are head team physicians. We have soon to be, in a couple of sequences, the president of the NFL Physicians Society is a nephrologist, right? There are cardiologists, we have PM&R docs, mental health. We have actually 2 full-time of our mental health clinicians on staff. We rely on our cardiologists all the time. Our dermatologist is maybe one of the busiest people. So the ecosystem of sports medicine, if you think, okay, I'm out here, this is kind of fun to be here, but I want to do dermatology. There are a lot of folks that have a great focus in sports dermatology. One, there's some of the infection part of things, but still all the coaches out there get skin cancer being out on the field all the time. Such there are a lot of ways, if you don't purely want to be a sports medicine doc, where you can impact this ecosystem, even on the basic science part of things. And now more than ever, I think the doors have opened where we all flow through and everyone's looking to communicate with each other. And most of the research stuff I've done, as I've been here for 12 years, were not in the Department of Orthopedics. The folks that I've interacted with were in cancer, in our biomedical engineering. I have 2 projects going with the dental school. And so keep your head up, go talk to all of your folks around you. It's a really great, you'll be really surprised at all of this stuff going around you. The final part I will bring is what we do with our the professional teams and what we do in the community are not mutually exclusive. When I started here, we had 4 high schools. Now we have over 80 high schools that we provide an athletic trainer and the physicians to, and then our other healthcare systems around do it as well. But everybody's got the unique parts about their program. I still cover high school football games on Friday nights. On Saturday, I go and cover the college games on Saturday afternoon, and on Sunday, we take care of the Browns. It's a very important part, and have all this stuff we do at the pro level. There's a lot of folks that say, "Oh, I'm just a pro doc. I don't want to deal with anything else." And I don't believe in that. I think it's really important for us to be involved in our community. I actually have as much fun at the Friday night games as we do at the Sunday games. So encouraging you, again, no matter what specialty you're in, you do have the opportunity to get outside of the walls of the hospital and impact your community. And all of those emergency action plans and all of those things we've done at the pro level, we do at the youth level. So I encourage you to do that in whatever way you could volunteer and get out into the schools. They love it. And even if it's having the students come and shadow you, it goes a long way. So a really great way to get out there. And I tell this is, and I'll end with this. If you are a budding sports medicine doc, this is my one soapbox thing. There are a growing number of what we call office sports medicine docs, right? You just want to sit in the office and say, "Feed me the ACLs on this wonderful surgeon, and I'll take care of it," but you don't want to go out and do the work. And I would charge you or tell you that you need to earn the right to take care of those patients. You got to get out of the hospital, get your feet in the grass, shake hands with the parents and the coach, and be there when those kids get hurt to help earn the right to take care of them in the office. It's one of those almost covenants that you have with your athletes. So I'll leave you with, do not be an office arthritis or an office sports medicine doc. Get out there with your feet in the grass in the community. I'll take care of that. With that, I'll stop. I know we have some question and answer part of things to do, and I appreciate the opportunity to chat with y'all here. So thank you.
Dr. Voos, that was an absolutely amazing talk. You have many hats. So as I listen to you, you're an occupational medicine doc, you're a high performance athletes doc, you do rehab medicine, you do preventive medicine, you're an orthopedic surgeon doing procedures, you're the chair of orthopedics, training the future healthcare leaders here in Cleveland and in the United States. And on top of it, you're a regenerative medicine specialist, you're an inventor, you're an innovator, you know about FDA regulatory programs. It's absolutely incredible that you can wear that many hats. I imagine, given your work with the athletes, you also have to be a little bit of a nutritionist too. And there's been a push recently for medical schools, almost a mandate, to have at least 4 weeks of nutrition in their curriculum. Can you tell us about how that is applied to your practice and what your thoughts are on it?
It's a great question, and the nutrition part of things often wax and wanes as it really raises its head as new things come onto the market or new fads or trends start to come. And right now it's as important as ever to know about nutrition. One is there's so many different compounds out there that your patients are going to ask you about. So I think we have a responsibility to have done the research and know, should I take peptides, should I take exosomes, how much creatine should I take? It's something where you think, gosh, why should I need to know this? But your patients trust you. So you need to be the voice of reason and to understand how to utilize those. And now even with the GLP-1 part of things, we have the first player in the NFL ever that's a very large player that's taking GLP-1s, but we have to give them enough protein to stay strong. And so that understanding what those principles are like, and at least having the basic level of this is safe, this is not safe, I actually think is really important. As with anything, the challenge is where do you fit it into the curriculum and how much time do you give? But whether it's an official part of your curriculum or not, your patients are going to ask you. So I would challenge you to go and educate yourself even further on it. It's a great question.
The other thing I noticed in your talk was that your players, the NFL players, it's a lot like taking care of fighter pilots. I was a flight surgeon for a long time with the Air Force, and you're talking about high performance people doing high performance maneuvers, and you want to keep them healthy, you want to keep them active, and as you mentioned, you want to keep them in the sport a lot longer. Now, I assume you have to be a psychologist too, so how do you deal with the reverse malingerers, those who want to play, want to be at practice, want to hide things from you? How do you develop a relationship to deal with that?
You know, at the end of the day, this really is a relationship business. And to be in this, the athletes are just like your patients. You cannot be a fan. You really have to get to know the athletes. And that's where we really argue for the role of a team physician. There's some people that think, oh, everyone should just go to some third-party neutral doc to give whatever level of care because they're totally independent. But that really falls against what medicine is, of the physician-patient relationship. So it takes being around enough. They have to see your face to trust you. You have to have, they know when there are challenging times you're there and you have their best interest in mind. When the players come down to see us, they know we shut the door, there's no coaches there, there's nobody else there. They know you trust them, they see you make those decisions for them and their teammates, and they'll talk, right? So if it gets around really quick if you're somebody that doesn't have their best interest in mind. So it's a lot of relationship building, spending a lot of time with them and knowing that they trust you. And you have to spend time getting to know them. I know who's living by themselves, or who has whose mother is sick, or who's helping to take care of their extended family. All those stressors come into play. So if they know that you have their best interest in mind, it helps you when you pick out those things, some good, some bad, or on either side.
So when you're on the field and you're managing the players, you spoke to us a lot about the number of specialists who are there and how you keep an eye on the players and you monitor the players. Do you also have a role in managing mass casualty response for the stadium itself?
It's a great question. So fortunately, I do not have to manage the stadium. Now we do have another specialty, which I'm glad you brought up. Our ER docs have done, two of our ER docs have done event medicine fellowships, where their whole part of being an ER doc is managing large-scale events. So when a like the Republican National Convention was here recently, or there's a concert, every time there's a concert at the stadium, we have two ER docs, and they have this amazing team of nurses and EMTs that manage the stadium, and they go through those, one, if somebody has a heart attack in the stands, but it's also, there's an earthquake, or if so there's an entire specialty in medicine from the event medicine side of things. That's great. We have two of our docs that do that, and fortunately they manage the 60,000 spirited fans, as we call them here in the stadium, that sometimes have a little more excitement than they planned on.
I'm sure we have a lot of questions from the audience. We have physicians and medical students and graduate students and other doctoral students with us here today. Can we take some questions from the audience?
Jim, that was the best, that was superb description of what team physicians do. I have had the opportunity for 4 years to do this. You didn't mention, I know what you do a lot is teaching too. And so getting a lot of the fellows that you train to go out, they go out, all of the fellows that I get a chance to train, they're getting to do all this fun stuff that you taught that I never had the opportunity to do. But seeing that wide-eyed look of people who think that, yeah, hey, we're in the hospital or we're seeing this, and then you get out on the sidelines and it's a little bit of a different situation, and you described it well. One of the things in the imaging and things like that, in Friday nights and in high schools, we don't have the opportunity. Ultrasounds becoming something that's being used more, but even in the high school setting, not so much. What do you have available to you, and how much imaging do you use in the
for the high school part of things, there's unfortunately not much here, and really, I think the key in taking care of the high schools, as we've done for a long time, is really getting a sense of what's dangerous or not, right? That's where you get a sense of, it's the triage of, this is a problem, we need to go have this looked at, or this is something that at least they can stay and continue to watch the game. I think a lot of the healthcare systems have managed that by, we do a thing called Friday Night Lights, where on Friday nights we stay open until midnight, a couple places around the system, so you can get that quick access to it where you don't have to sit in the emergency department. But I think the main part of it is being able to have that comfort level of evaluating what's dangerous and what's not. And you do with our trainees, the owners of the Browns, Dee and Jimmy, have been wonderful. Our fellow, everything I do, the fellow does. All the goods and the bads, our fellows get to see and really experience. And you have to go to thousands of, hundreds of games to see it, because you're gonna go to 50 games and nothing happens. You're gonna go to the game 51, somebody's gonna try to die, right? And so you've gotta have done the emergency action plan. You've gotta be ready to go, because it's a lot of sitting around, but then something really bad happens and you've gotta be ready to react. And you have to see it enough for it to have gone through that response. So as a student, we love having people come shadow, and there's 80 high schools. We have more than enough schools to come out and see things, so we're always happy if that's something of interest to do. That's a great point.
So there's an opportunity for students, medical students, to volunteer and to be paired up with some of your clinicians that are supporting high schools or college ball right now?
Yeah, that's right. So at every game, there's an athletic trainer and one of our team docs. So you won't be there by yourself. You're going to be there. And the good part is, so you get to learn the environment of being at the games, but you have two people to educate you there, both the physician and the athletic trainer.
Other questions from the audience?
Hey, Dr. Voos, thanks a lot on the talk. I found the part with the smart sensors really interesting, and how you can manage your / monitor massive events. What do you see as currently the barrier to implementing it in big public events / the path forward? And I'm thinking of something like, let's say, the Cleveland Marathon, where you had it anywhere from people that do a 5-minute mile for 26 miles because it's fun, to weekend warriors who are on the very other end of the spectrum.
Two parts of it, or three parts. One is the cost used to be very prohibitive of the sensors, and then deciding what sensor are you going to buy or not buy, or if you're the marathon, what sensor are you going to provide for everybody running? And so that's a little bit, I think you'll see more and more of that. If you sign up for this event, we're going to provide you with this technology to participate in. That cost is coming down. The second is the device's ability to channel large groups of data. Like you can track your data, or I can track your data very easily, but to have the system be able to input 5,000 people, catalog that, and what are you looking for, or what are your parameters of which you're going to be able to manage 5,000 people. So having your software be able to pick out who's having trouble in this giant dashboard of folks, so it's not an overwhelming amount of information. That's number two. And then the third is people just ultimately having comfort levels with it. And I think it's still very dichotomous. There's a lot of real techie people that jump in. A lot of other people are still kind of nervous. I don't know if I want anybody to know my data or not. But the first two, I think, are the most important. The cost is coming down, and then we're able to generate the data. It's the synthesis and monitoring of it, of who's responsible for it, what data points are you looking at. But that's every year, that's getting easier and easier and easier. That's a great question. Whether you like it or not, your clothes are going to start talking to you. They're going to monitor what you do. So a lot of the sports clothing, it's going to be integrated into your clothing here now more and more as we move forward.
Building on that a little bit, is it an obligation contractually for the players to be monitored, or do they have the ability to decline?
Yeah, it's a really great question. So the players' data was collected in this thing called the collective bargaining agreement that the players work through a union, and the data was discussed as this personal health information. This is my private information. So in the NFL, the players own their data. So they can decide whether they want to be monitored or not. So if they do not want to wear a monitor, they do not have to. And then what we do with that data in terms of the NFL buying or selling that data or doing research on it cannot just be done openly. We actually have to go through all of our normal IRB process and then work through the Players Association to get permission to utilize the utilize the data. So it's interesting. There's a whole legal part at CASE. That's a whole sports law group that not only is doing with NIL, but then whose data is what and how it's valued. And currently the players own their own data. Another question?
Thank you, Dr. Voos. I know that you've mentioned over the past couple decades, player health and safety has become a lot bigger focus of the NFL, certainly since the current stadium was built. I'm curious if, with the new stadium being constructed, if your team has any opportunity to give input on that or implement new technologies, especially as the NFL has become more standardized, as you alluded to.
Yeah, it's great to even just to be a part of seeing how the locker rooms are set up in the flow of how, when you take a player off the field, what's the ease of access to X-ray, and can you flow right through X-ray and into the locker room, or if you have to get into the rig for the ambulance. You know, some stadiums you almost go 150 yards by the time you go across and around. And one of the stadiums that's no longer existing, you used to have to go outside and get on a golf cart and go around. So that part of the flow is really important. The tech part is really fun. So when we get all the new X-ray machines and all of that stuff. But now, Major League Baseball is using it now, and so is the NFL. It's a camera system called Hawkeye. That's these cameras that surround all the way around the stadium. You get you see all those 360 surround sound part of things. So you get those cool visuals on the field, but behind the scenes, what we get at the NFL level is we can track every single player. And for example, we know that when a player steps wide and decelerates at a certain angle, they're more likely to tear their ACL. We can, from that Hawkeye data, take that player with 22 people running around, peel off that player, and it can do the measurements every single time the player cut with his right foot in the game and overlay those over each other. And maybe he did it 21 times, and it will show the 20 times that he cut, he was within the frame of his body. The one that he tore his ACL, he cut way outside of it. So the amazing part is that those cameras can pick one player out, measure down to the angle of their knee, and show, okay, most people that tear their ACL, their body does this. You saw Micah Parsons as a perfect example, right? The defensive end for the Packers stepped just outside of his body. He was the one they used as any example. He cut like that like 30 times during the game. But that time he was just outside the frame of his body. So that helps us to train players. When everybody's doing all their shuffle drills and cone drills, it's not just see how fast you can do it. Now you're trying to train into that muscle memory. If you're going to change direction, this is the plane you want your body. Or when you tear your Achilles, people doing the drop step, you set your foot back. You see it in the NBA all the time. Now they're training players. One of the things, instead of coming straight back, they train you to tee your foot. So when you come back, you turn your foot out to the side and then push off. So even that, just getting that into your muscle memory to T-step instead of straight step back is all from those type of technologies in the new stadium. So it's amazing those little details that we're able to carve out of it.
Other questions from the audience?
So for someone who's the daughter of an athletic trainer at a high school, like you've talked about working from like the top to the bottom, and especially that technology to help with like rehab and standardization of that rehab. If you had to pick out, say, like one toy or one modality for like a high school where funds might be limited, things like that, what would be like the one thing that you would recommend at like a high school level to help on that journey?
You know, there are the major manufacturers, and I have no connection with the Zebra and Catapult are the two major ones that I use. I have no connection with any of them. But each of those type of companies have these super souped up versions that they use in the NFL, but they all have one layer down, which gives you most of the key data points. So a lot of schools have adopted those because you can use them over and over and over again, right? What you just, after each practice, they go and they put them back in the rack. So those are being adopted more and more and more. But even things as simple as the pressure plates, if anybody's seen the pressure plates, when you go and people lift and do functional movements, movements on them, and you can see the difference between your right, or asymmetries between your right and left if you jump, how you land. So even those can give you some data that's at least quantifiable in a functional movement screen to see, okay, you're favoring this or that. So those are super achievable and very usable. But we get this question all the time from the parent teacher or from the booster clubs. What can we do? And so we make sure the number one thing you could have is an ice trough, right? So you can dunk somebody so they don't overheat and die, right? So an AED and an ice trough are going to save everybody's, an ice bath are going to save everybody's life. So we always tell them, the booster clubs, make sure your club has those two things. But then the really interested ones are that want to do fundraising part of things. We talk about these kind of the universal version of some of these GPS devices are really, really helpful.
Other questions from the audience?
I read a brief article through UH regarding, I believe they're called the brace shoelaces.
Yes.
Can you talk a little bit more about those?
Yeah, so our Haslam Sports Innovation Center, I know we do some very similar type of things. We have a contest each year. Last year, one of our companies that got was second place are two college students from Michigan State. They're 20 and 21 years old, engineering students that came up with a shoelace made out of a substance that doesn't break and doesn't come untied. And they had a bunch of athletes wearing these that loved them. So we were one of their first investors to help with the startup side of things. And you don't think shoelaces are a big deal until a shoelace breaks or your shoe comes untied. If you play hockey and your brace or your shoelaces break, it's a horrible thing. If anybody that skates knows it's a big deal. A couple of our players last year had shoelaces break at the wrong time in the game, and they missed 3 or 4 plays, and it's a big deal. So this company, these two college kids came up with it, and these shoelaces, when you tie them, they really don't break. They don't come untied. And it was fun because last year we were one of their discoverers, and 2 Wednesdays ago, they were on Shark Tank and won. They got funded on Shark Tank, so it was awesome. It was like this super emotional thing. So for us, it was really cool to see this group that totally fit what we're trying to do. They care about safety, student entrepreneurs, it fits a need. We were able to support them. We're doing a bunch of studies on the shoelaces, the loosening of the shoes, and then to go and tell the story and see them succeed. It's the perfect example of and it's shoelaces, right? It's like, gosh, we're doing all this super techie stem cell stuff. I should have made shoelaces, but it's a perfect example of how you can move things forward. They're really, really fun company. Great. They're 2 Michigan State students.
You had a question?
Yeah. Thanks, Dr. Voos, for the talk. You mentioned about preventing head injuries, especially in the technology we have in helmets. Can you talk a little bit about how we progress from that and how we counsel athletes as well as even at the professional level in terms of head injuries, just given the recent early retirements from a couple of NFL guys?
Yeah,
it's concerned about concussions.
That's a great question regarding managing head injuries. I'll give you 3 steps to it. One is we screen people ahead of time. They have a history of concussion, anything like that in the past, but more important, do they have untreated ADHD? Do they have untreated anxiety? Do they have untreated sleep disorder? We know the athletes with those 3 things have prolonged and atypical symptoms with our concussions. So now we know we screen all of our athletes, a mental health screen, a sleep screen, ADHD, and all of the learning disorder type of screens, make sure that those are addressed and fixed up front. So it's a very big deal, really helped athletes. And we've received numerous follow-ups from our athletes of doing that screening. Again, similar thing that we feed to our college and high schools. Those are very easy things to screen for. So that's number one. The second is the equipment changes. It's the helmets. It's not smashing each other in practice every day, teaching you how to tackle better and all that. So it's the rules changes, the kickoff rule and all of those type of changes. So it's equipment and rules changes. The most important part is we've educated the athletes on what a concussion is, the importance that it is, what it has to do with how it can affect their career. And now most of our concussions are because the athlete self-reports or one of their teammates reports, hey, he's not right. And that is a huge change from the gladiator mentality of, I'm going to go out there and not tell anybody. And so I think that's been a huge culture change to educate people. Hey, if we identify this now and do everything right, probably only going to miss a couple days or 5 days or so when you can play this week. If you let these things linger, it's going to become a bigger problem. And then there's all the concussion protocols and such here afterwards. But I think all of sports have done a really good job with it. I think the NFL has done with all of the exposure before, I think has led the way. And I think that's flowing into all of our other sports here now. That's a great question.
So last question for you. You've been involved in technology development and innovation from devices to biologics and fashion. Which is your favorite and why?
I still, at the core of all of this being a surgeon, I think the devices For me, the devices we can use in the operating room, to me, still are the most exciting. I think there's a lot of the things that are fun, but to me, my goal, this is actually an interesting question to make me think about it. My goal as a surgeon, if I were to do one thing, I do ACL surgeries or what I do most of every year. If I can end my career and we no longer have to steal your patellar tendon or your quad tendon to do your ACL, the morbidity of doing that, if we can repair, heal, collagen scaffold your ACL and no longer have the morbidity of stealing from you, that is my biggest scientific career goal. So I think the tissue engineering part of things is the one that excites me the most, or at least I've challenged myself to try to be a part of that solution. It's a great question.
It's amazing. Please join me in thanking Dr. Voos.
Thank you very much.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.